Hello viewers, good day to all of you. This is Dr. BK for you. In this session, I am going to discuss about the circulatory system. Now, first, let us see the objectives of today's session. So, in this session, we are going to discuss introductory remarks about the circulatory system, classification of the blood vessels, so based on their function. Then we are going to actually discuss few points regarding the various types of circulation, then the structure of blood vessels, the various types of blood vessels, how do they differ in their structure, then the characteristic features of the arteries, veins and capillaries, then about sinusoids, what are sinusoids, what is the anastomosis, and some applied aspects. Now, first of all, the circulatory system is actually called as a transport system, which is mainly responsible of supplying the nutrients to the tissues of the body and the removal of the waste products. Now, broadly, the circulatory system can be classified into the arterial system and the venous system. So, the arterial system takes the blood from the heart and distributes to the whole of the body, except one set of arteries, which is the pulmonary arteries, which carries deoxygenated blood to the lungs. Venous system carries the deoxygenated blood from the periphery and it actually brings the deoxygenated blood to the heart. And here also you have one exception. The pulmonary veins from the lung, they actually carry oxygenated blood from the lungs to the heart. So a correct explanation of an artery and a vein would be all the arteries branch out or move away from the heart. They carry blood from the heart, but whereas the veins carry blood towards the heart, or all the veins are actually focusing or traveling towards the heart. So mainly what happens is the atria, the chambers, you all know that the atria, the right atrium and the left atrium, they receives blood through the superior vena cava and inferior vena cava, that is the right atrium receives these two vessels and pulmonary veins open into the left atrium. The two ventricles pump the blood through the aorta and pulmonary arteries. The aorta pumps the blood from the left ventricle to all parts of the body. The pulmonary arteries pump deoxygenated blood to the lungs for it to get oxygenated. So the components mainly of the circulatory system is blood is actually transported mainly to the arteries, veins and capillaries. So the components are the arteries, the veins and the capillaries. There is another system which is called as the lymphatic system. You are able to see in this green color, they are lymph nodes and they will be connected by lymph vessels. But ultimately what happens is whatever is collected through the lymphatic system has to come and join the venous system. So that is why lymphatic system is actually considered as an accessory to venous system. So we are going to see about that lymphatic system in a separate session. Now, all the blood circulating through the body at any given time is actually 5 liters per minute, which is the cardiac output. So here you are able to see these arteries. Arteries branch out to form arterioles, and the arterioles, again what happens, forms capillaries. So capillaries is actually a connection between the arterial system and the venous system, and in the capillaries the exchange of nutrients is going to take place. On the other end of the capillaries, you see the venules are formed, then small veins, they open into very large veins, and finally what happens is these veins open into the heart. So you have the arteries, arterioles forming the capillary plexus, venules, veins, and then large veins. Now, functional classification, you can classify all the blood vessels in the body into conducting vessels. So they are responsible for conducting the blood, or what happens is they are the large vessels, like your aorta is a very good example of the conducting vessels. The next line of vessels from the conducting vessels is the distributing vessels, the small arteries. The next line of vessels, brachial artery, femoral artery, axillary artery, they are actually called as distributing vessels. Then from those vessels, what happens? You get arterioles. So these are the arterioles and terminal arterioles. They are resistance vessels. Why do we call it as resistance vessels? Is they are responsible for the peripheral resistance, and we all know that this peripheral resistance is actually measured and what we call it as the blood pressure. So mainly the terminal arterioles are the resistance vessels. Then from these vessels, because they also possess something called as the precapillary sphincters, then we have this capillary bed. From the capillaries, what happens is the post-capillary venules, they start. So they are the exchange vessels. I already told you in the last slide that the capillary vessels are mainly involved in the exchange of nutrients. So that is why they are actually called as exchange vessels. Then what happens is, next is the capacitance or reservoir, which are the venules, large venules and veins. Because what happens is, why they are called as reservoir vessels is because some amount of blood actually they get dilated sometimes, and blood is actually flows more to the veins, and that is why it is actually called as capacitance or reservoir. So conducting vessels, distributing vessels, resistance vessels, exchange vessels, and then capacitance or reservoir vessels. So few functions regarding the circulatory system. You all know that the blood vessels are responsible for the distribution of the oxygen and the collection of the carbon dioxide. Then they supply nutrients. So all the tissues receives the nutrients where through the exchange vessels. The hormones which are secreted by the endocrine glands, because we all know that the hormones have widespread effect throughout the body because they are directly poured into the bloodstream. So bloodstream take the hormones. Not only carbon dioxide, other waste products like ammonia, nitrate, and all those things are also removed by the circulatory system. Then the components of immune system, because immune system, the WBCs, the phagocytes, and whatever is actually produced from the bone marrow also has to travel through the circulatory system. So the components of immune system is also formed by the circulatory system. Thermoregulation. So maintenance of temperature is mainly achieved by vasoconstriction or vasodilatation. So thereby they are also involved in the thermoregulation. And of course, we use the blood vessels for recording the blood pressure and also the pulse, arterial pulse. So coming to the types of circulation, we have mainly systemic circulation in our body, pulmonary circulation, which is mainly concerned with the lungs. Then you have something called as portal circulation, which you are able to see in the gastrointestinal tract and also in the pituitary gland and in the kidneys. Then fetus is, in the fetus you see a little slightly modified type of circulation. So we will see these four types of circulation one by one in brief. So systemic circulation, I need not explain to you much. You all know that it is distributed to, blood is distributed to all parts of the body. So from the left ventricle, the blood is pumped through the aorta and is distributed via the arteries, arterioles, and from there blood is collected from the capillaries to the venules, veins, and then ultimately it reaches the right atrium by two large veins, that is the superior vena cava, which actually collects blood from the upper half of your body, especially neck and the head region. Below the diaphragm, that is from the lower limbs, and from the abdomen, it is actually collected by the inferior vena cava. So systemic circulation is mainly concerned with the distribution of blood to all parts of the body, and then collected of the blood to the heart. So next type of circulation, what you see is the pulmonary circulation, which you see in case of the lungs. So this deoxygenated blood which has been received by the right atrium enters the right ventricle, and from the right ventricle through the pulmonary trunk, which divides into two pulmonary arteries, the blood enters into the lung. So near the alveolar sacs, it is actually the capillary plexus is present surrounding each alveolar sacs, where the exchange of the carbon dioxide and oxygen takes place. The oxygenated blood starts from the post-capillary plexus, venules, and what happens is the pulmonary veins are formed. So two pulmonary veins for each lung, whereas only one pulmonary artery for each lung. So ultimately 4 pulmonary veins from both the lungs comes and ends into the left atrium. The next type of circulation, which you might not be aware much, is the portal circulation. It is nothing but an offshoot of systemic circulation, because ultimately the blood has to reach the systemic circulation. So here you are able to see this area depicts about the portal circulation. Now portal circulation means, basically what you should remember is, there is 2 sets of capillaries are present. Now here we are going to see the portal circulation of the intestines. So first set of capillaries starts from the intestine, and what happens is they form a vein which is actually called as the portal vein. From the portal vein, as it enters the liver, it breaks into another set of capillaries, and then the hepatic vein is formed, and ultimately this hepatic vein has to open into the systemic vein, which is the inferior vena cava. So from the intestinal capillaries, one set, portal vein. Then what happens is another set of capillaries. Here we don't call it as capillaries because it breaks into something called as sinusoids inside the liver, and ultimately what happens is hepatic vein is formed, which transports this venous blood into the inferior vena cava. So this is about the portal vein in the intestine. The next type you are able to see in the pituitary gland. Again 2 sets of plexus are present in the infundibulum and in the lower part of the infundibulum by the hypophyseal arteries. This is actually called as hypothalamo-hypophyseal circulation. The next type, one more type of portal circulation you come across in the kidneys. In the nephrons, you can see one set of capillary plexus. The glomerulus is a tuft of capillaries. Then efferent arterioles, they start, and what happens is from there you see another set of plexus which is actually called as the peritubular plexus. So 2 sets of capillaries are present, which is a characteristic feature of any type of portal circulation. So I have seen portal circulation in the intestine, we have seen the portal circulation in the pituitary gland, hypothalamo-hypophyseal portal circulation, and renal portal circulation. So next we will see in brief about the fetal circulation. So what happens in the fetal circulation is blood from the placenta enters via the umbilical vein. So here you are able to see the umbilical vein. This umbilical vein actually bypasses the liver because intestines are all not active. So even though the portal vessels are slowly developing, not much activity is taking part here. So naturally what happens is there is a shunting of blood and enters the inferior vena cava. Now after that what happens is blood from the IVC and also from the SVC enters the right atrium. From the right atrium, you are able to see some amount of blood directly goes to the left atrium. So again, there is a shunting of blood. So why? Because lungs are not functional. So no oxygenation takes place in the lungs. So that is why there is a shunting of blood between the right atrium and the left atrium. Even though some blood enters into the pulmonary artery, and again you are able to see a communication between the pulmonary artery and the arch of aorta. So there is a mixing of blood. Then what happens is, from there the blood from the aorta actually leaves through the umbilical arteries again to the placenta. So from the umbilical vein, it bypasses the liver, goes to the right atrium. From the right atrium, some amount of blood is directly passed to the left atrium. And the same way, what happens is, some amount of blood from the pulmonary artery is actually shunted because there is a communication between the pulmonary artery and the aorta, which is actually called as the ductus arteriosus. So one interesting thing to note here, you are able to see naturally the umbilical arteries carrying deoxygenated blood. And here umbilical veins are actually carrying oxygenated blood. So there is also exception in the fetal circulation. So again I would like to reiterate the same point, that veins carry blood towards the heart and arteries carry blood away from the heart. So next we are directly going to the types of blood vessels based on their structure and size. They can be classified into arteries. Two types you come across in the arteries based on their size: elastic arteries, which are very large arteries, and then you have muscular arteries, smaller arterioles, then we have capillaries and sinusoids. In some place capillaries are replaced by sinusoids, and then we have venules, and these venules join to form the veins. So this is the decreasing from increasing order, from larger size decreasing up to capillaries, and from there again they increase to venules and large veins. So arteries, arterioles, capillaries, venules and veins are the types of blood vessels. Now a basic pattern is followed with respect to any blood vessel you take, whether it is a large or medium sized artery, and from there venules or veins. It possesses three coats from inside to outside. Tunica intima is the innermost coat, followed by the middle coat, which is actually called as the tunica media, and the outer coat is actually called as the tunica adventitia. So again I will repeat, three coats are tunica intima, tunica media and tunica adventitia. We will see the characteristic features of this each and every coat one by one. So here you are able to see the tunica intima. It is characterized by the presence of the flat endothelial cells. So squamous cells they are called as. So flat endothelial cells are actually present. Then next you have a subendothelial layer. This is actually called as the subendothelial layer, and it is limited by a lamina. So all these things contributes to the tunica intima. So you have the endothelium layer, subendothelial cells, and then what we have is the lamina, which is actually called as the internal elastic lamina, which consists of some amount of elastic tissue or fenestrated elastic tissue. So fenestrated means, the meaning of fenestration is pores. So you have pores, so that is why it is actually called as fenestrated tissue. So tunica intima, I repeat, it is characterized by the flat endothelial cells, then you have the subendothelial tissue, and then you have the internal elastic lamina. Tunica media, the thickest of all the three coats or the tunics we call it as. So here you are able to see the tunica media mainly consists of the smooth muscle fibers, In between the smooth muscle fibers, you also see the elastic fibers. The distribution of smooth muscle fibers and elastic fibers differs between the size of the artery itself, from large artery to medium sized or muscular artery. And of course, definitely in veins, there is a difference in the smooth muscle fibers. So the smooth muscle fibers might be anywhere from 2 to 3 layers to 20 layers. It may be circular smooth muscle fibers, or sometimes it might be follow a spiral pattern. Then it is limited by external elastic lamina, which is again a fenestrated tissue. So the tunica media is between the internal elastic lamina and the external elastic lamina. The next outermost coat, or the toughest coat, we call it as the tunica adventitia, the outermost coat. This is actually called as the tunica adventitia. So here you come across collagen fibers and elastic fibers. So more amount of elastic fibers in elastic arteries you see. So they are mainly responsible for the resistance of outward pressure, because the blood flowing inside the lumen, what happens is, tends to exert a pressure on the wall of these blood vessels. So that will be resisted by this tunica adventitia, thereby it prevents undue stretching. Otherwise, what happens is, it might lead to rupture of these vessels. And you are able to see some nerves are also supplying the outermost coat, which is actually called as the vasovasorum and vasonervorum. So vasovasorum is mainly a blood vessel supplying a blood vessel. Vasonervorum is a nerve which is supplying the blood vessel. The vasovasorum is mainly responsible to supply the outermost coat, because the endothelial layer and to some extent the media, what happens is, it is actually supplied by or receives its nutrition from diffusion of the blood flowing inside the lumen. But the outer coats, definitely, especially in the large arteries, they need vessels which has to ramify and supply the outer 1/3 of your blood vessel. Vasonervorum, they are actually autonomic in nature, so mainly they are responsible for vasodilatation or vasoconstriction, and they cannot bypass the smooth muscle layer beyond that. Okay. Now we have seen the basic structure of a blood vessel. It consists of 3 tunics, that is the tunica intima, then you have the tunica media, and then what we have is the tunica adventitia. We have seen the characteristic features of the intima, media and adventitia. Now we will see how these structures or these 3 layers are altered in the different types of blood vessels. So sub-classification in the arteries. First is the elastic artery. They are actually called as the large arteries because the lumen is very wide. Elastic tissue is very much predominant in the tunica media. So one thing is, the elastic tissue is very much predominant. You see a lot of these green color lines on the elastic tissue. The internal elastic lamina, which separates this from the tunica intima, and the external elastic lamina is poorly developed, not very much well developed in case of the elastic arteries. Then you have this tunica adventitia, which consists of collagen fibers and elastic fibers. This is also very thick tunica adventitia you see. So mainly the elastic nature is very well developed in case of the elastic artery. Why? Because this large amount of blood will be flowing. That is why. An example of the elastic artery is the large aorta, coronary arteries, then common iliac arteries. So these are all the elastic arteries, and we can, and based on their classification, you can actually classify them under the conducting vessels. The next type is the muscular arteries, which is also called as the medium sized arteries. From large artery we call it as medium sized artery, because here the tunica media consists of large amount of smooth muscles but less amount of elastic fibers. These responds to the nerve stimulus. So they might alter the size of the lumen, they might decrease or increase the size of the lumen. The internal elastic lamina and the external elastic lamina are very well defined in case of the muscular artery. So examples of muscular arteries are your brachial artery, radial, ulnar, femoral artery, tibial arteries, popliteal arteries. So these are examples of muscular artery. Functionally they come under the distributing vessels. The next, smaller branches from the medium sized arteries. What happens? You go to the arterioles. So terminal arterioles, and what branches from the terminal arterioles is the meta-arterioles. So these are the meta-arterioles which is branching from the terminal arterioles. The size of lumen is very small. They might range anywhere from 1 micrometer to 20 micrometer in diameter. Their whole thickness might vary from 50 to 100 microns, but the internal lumen diameter I told you, which is from 1 to 20 micrometer in diameter. The meta-arterioles are characterized by the presence of pre-capillary sphincters, and you all know that because of this, they are responsible for the peripheral resistance, because they actually exert this pressure on the wall, which we recorded as the blood pressure. So arterioles, terminal arterioles, branching out from them is the meta-arterioles, which actually ends in these capillaries. The next is the capillaries. Usually the capillaries are actually present in the form of a network. When we see the structure of the capillaries, you have an endothelium, tunica intima, and what happens is there is no smooth muscle here, absence of smooth muscle fibers. The endothelium might be smooth or it might be fenestrated. When it is smooth, it is actually called as continuous capillaries, and here what happens is it is fenestrated. They are all exchange vessels, so exchange of nutrients, any molecules which are going to pass out from these capillaries into these tissue spaces takes place. So thereby the capillary, what happens is their length also might vary. In the skin you have capillaries which are of bit larger in size compared to other spaces. So as I told you, the continuous capillaries are mainly seen in the skin, connective tissue, muscle and lungs. No fenestrations are observed here. Whereas fenestrated capillaries are mainly seen in the renal glomeruli, endocrine glands, pancreas and intestine. So mainly fenestration is because they can allow some particles. So large molecules can actually pass out from this renal glomeruli, and naturally secretions of the endocrine gland to enter into the bloodstream, pancreas and intestinal villi. So here absorption of nutrients. So for that purpose, what happens is large and fenestrated capillaries you are able to see here in these places. So capillaries, you have continuous capillaries, and next is the fenestrated capillaries. Now in some places the capillaries will be replaced by sinusoids, and these sinusoids are actually called as the large irregular spaces only lined by endothelium. Large spaces lined only by endothelium, no smooth muscle cells, and they might also be fenestrated. So that means with pores you can see that. Okay. So they replace the capillaries, and they are mainly seen in the liver. They are called as sinusoids of liver. In the spleen also you see the sinusoids, and also in the bone marrow. So absolutely no smooth muscle fiber at all, only lined by endothelium. They contain some phagocytic cells for the defense mechanism. So as I said, mainly detoxification where it is going to take place in the liver and also in the spleen. So that is why the presence of phagocytes is the characteristic feature of these sinusoids. So coming to some applied aspects Mainly we use the arteries to record the blood pressure and also for recording the pulse, arterial pulse. So blood pressure is recorded through the brachial artery, and through a sphygmomanometer you record both the systolic pressure and the diastolic pressure. Atherosclerosis is actually what happens is, if some substances, it is actually called as plaque, atherosclerotic plaque, when gets deposited leads to narrowing of the arteries. Now this is a procedure what you are able to see here, how the atherosclerotic plaque is removed. One of the coronary arteries of the heart is slowly narrowing as take place due to deposition of this plaque, lipid substances. So a stent is placed, and through this procedure is called as angioplasty, balloon angioplasty, because what happens, the stent is placed by what happens, by expanding the artery they are making to bulge or inflation, it is actually called as inflating. So this plaque might break and get dislodged, and to prevent further narrowing, what happens, a stent is actually placed. Atherosclerosis. And what is embolism? And followed by embolism, what you are able to see here is what is a thrombus. So here embolism and thrombus is a blood clot. When this blood clot get moving, then it is actually called as an emboli. So an emboli is a moving clot. That is also again dangerous, because from larger arteries, when it moves, it goes to a smaller vessel. You are able to see the vessel getting narrowed down. It might get stuck there, completely obstructing the lumen. Then naturally what happens is, because of that, one thing, the vessel might rupture, creating hemorrhage, and because of that the tissue might lose its blood supply and there might be complications arising out of it. So that is a thrombus which you are able to see from this large clot. Slowly what happens is, a part of it breaks and travels, fragment of blood clot, which is actually called as embolus, most commonly seen in the veins. So a hemorrhage is actually a rupture of vessels. The vessel wall ruptures. Vessel wall ruptures most commonly seen in the cerebral blood vessels, and because the resultant is actually called as a stroke. The vessel wall might rupture. One I told you, because of the embolus it get blocked, or due to high blood pressure. So because the small vessels offers peripheral resistance, when they cannot withstand that resistance, what happens, they might rupture and leading to hemorrhage. Now we have seen about the arteries, the characteristic features of the large artery or elastic artery, then the muscular artery, then we have seen about arterioles, capillaries and sinusoids. So now we see about veins. Smallest veins are called as venules, which starts from the other end of the capillaries, post capillary you call it as. Then the smallest veins unite to form superficial veins, and the superficial veins go and drain into the large veins, which are usually present in a deeper plane. Your superior vena cava, your inferior vena cava, brachiocephalic veins, they are all present in a deeper plane. Superficial veins are mostly seen on the superficial aspect. A lot of veins you see subcutaneously below the skin, and the branches are actually called as tributaries. So venous tributaries you call them. They are actually characterized by thin lumen which is irregular. Usually it is for diagrammatic purpose, it is actually shown as a round, but usually the vein lumen will be collapsed or irregular. You don't find a very regular round lumen. Less amount of muscular and elastic tissue in the tunica media, poorly developed tunica media, but adventitia is very thick, and sometimes you come across smooth muscle cells in the tunica adventitia, especially in the large veins. Then one characteristic is venae commitans, which you come across in the limbs. That is, venae commitans is a pair of veins traveling along with the arteries. Now why do they travel along with the arteries is because The arterial pulsations is utilized by these venae committents for the effective venous return, and as I told you, this venae committents is most commonly seen in the limbs. So large veins are mainly characterized by the tunica adventitia. See, the thickness of the tunica adventitia is more than the tunica intima. I told you a lot of elastic fibers are seen, and not only that, smooth muscle fibers are seen in the tunica adventitia. Characterized by vasovasorum, large vessels usually have smaller vessels supplying this, and presence of valves. One example is the subclavian vein you come across. Then you have femoral vein where the valves are actually present. Mostly in the veins of the lower limb you have this, but valves are absent in certain places. That is the very large veins, vena cava. Superior vena cava, naturally the venous return, the gravitation itself is going to aid in the venous return, vena cava. Vertebral veins, the veins are absent in the vertebral veins. In the hepatic and renal and pulmonary veins, all here what happens? The valves are absent. So basically we have seen about a large vein. Venules are mainly formed by the convergence of capillaries. So leukocyte migration takes place. So here you are able to see a small venule, very poorly developed tunica intima, and adventitia is also very thin. Only thing you are able to see the endothelial layer, the intimal layer. So leukocytes migrate out into these tissue spaces. So mainly for the defense mechanism and phagocytic functions. Okay. In certain veins, in the cancellous bone and the cranial venous sinuses, you have some venous sinuses within the skull, intracranial venous sinuses. They completely lack smooth muscle. The smooth muscle layer is completely absent in certain areas, like in the cancellous bone veins and also in the cranial venous sinuses. Okay, whereas valves are absent in very large veins, the vena cava. Vertebral veins and hepatic and renal veins lack valves. So applied aspects of veins, mainly intravenous injection. So when you want to inject certain dyes or drugs, then naturally what happens? It is given into veins. Here you see different types of injections: subcutaneous, muscular, and intravenous and intradermal injection. The angulation of the needle has to be taken care so that you perfectly inject into the vein. Phlebitis is a condition where the veins get inflamed. Inflammation may be due to injury, may be due to pricking injury or some other reasons. So inflammation of the veins, and naturally what happens is clot might be formed due to trauma in the vein. Varicose veins is due to prolonged pressure in the veins which lead to stretching, and the vein gives a wriggled appearance. This is actually called as varicose veins, most commonly seen in the lower extremities, and it is actually seen as an occupational hazard in certain persons who stand for a longer period of times, the traffic policemen or teachers who stand for a very long period of times. Naturally what happens is vein gets wriggled and the valves get leaky valves you come across in the varicose veins. Deep vein thrombosis you are able to see here. So thrombosis is collection of blood clots. You see the deep vein thrombosis. Next we will come to the difference between the artery and a vein. So far we have seen the various characters of different types of arteries and vein. To summarize, if you look at the lumen, very definitive lumen, regular lumen with thick wall. Here it is collapsed lumen. The endothelium or the tunica intima is usually rippled, and internal elastic lamina is present. Here it is not rippled, it is very smooth, and internal elastic lamina is absent. Tunica media is thick with abundant smooth muscle and elastic fibers. Here smooth muscle fibers are very sparsely distributed and collagen fibers are present instead of the elastic fibers. External elastic lamina is present and here it is absent. Tunica externa you have collagen elastic fibers. Apart from that, in large veins you also see smooth muscle fibers. Valves were absent in arteries. Only thing you have some precapillary sphincters. So sphincter is something different from a valve. Valve is present inside the lumen, whereas valves are actually present in the veins. So this is a summarization of the characters of the artery and vein. Now we'll come to what is called as anastomosis. So an anastomosis is a communication between two blood vessels. It might be prior to the capillary formation at the pre-capillary level, or it might be at a post-capillary level after the formation of the capillary plexus. Now why actually this anastomosis is needed is, it is an alternative route of circulation, because if an artery is blocked at any point, then naturally the blood has to find an alternative route to reach the target areas. In that case, that circulation is actually called as collateral circulation. Collateral circulation. So to put it in terms like, if an artery is blocked in the heart, then naturally we develop through a surgical procedure a collateral circulation by connecting these two blood vessels, bypassing the area of block. So that is what is actually called as a coronary bypass or a bypass surgery. So collateral circulation is when these anastomotic channels become operative. So that is when it becomes functional, and most commonly given example is the coronary collaterals, when the occlusion takes place in the coronary arteries. So an anastomosis is actually a communication between two vessels. So the types of anastomosis, as we see, three types we come across. Between the artery and artery, it is called as interarterial anastomosis, or it might be between an artery and a vein, it is actually called as arteriovenous anastomosis, or it might be between the veins, which is actually called as venous anastomosis. In case of arterial anastomosis, there are two types. One is actual and other one is the potential anastomosis. Actual anastomosis is when the arteries are connected with each other and blood flows through them continuously. This is palmar arch. Here you are able to see an arterial anastomosis, which is seen in the palm. That is actually called as palmar arterial anastomosis or palmar arches. You have superficial palmar arch, you have deep palmar arch. Same way, arterial anastomosis is also seen in the thighs, because palm, we might actually clench our palm, we might do so many activities. So in that cases, blood supply should not be compromised, especially to the digits. So that is why you see a arterial anastomosis. It is almost active and functional. So that is why it is actually called as an actual anastomosis. The next is potential anastomosis. Communication is between the arterioles, but they are not perfused by blood. A good example is right and left coronary arteries. So they anastomose at the arteriole level, but what happens is blood does not pass through them, always between these small branches. So it is potential anastomosis. Now when any block develops within these arteries, slowly what happens, the collaterals develop and the collateral circulation starts. If the block is actually gradual as the time advances. So collaterals develop usually in elderly patients in the coronary arteries. If there is a sudden block, then naturally what happens is this potential anastomosis will not be able to form a collateral circulation. Okay, so that is the difference between the actual anastomosis and the potential anastomosis. So that is for you the potential anastomosis between the coronary arteries, the arterioles. They form an anastomosis, but perfusion does not take place. Next is arteriovenous anastomosis. A communication between the arterioles and venules bypassing the capillaries. This is mainly responsible for regulating the temperature and increasing portal venous pressure. So these type you come across mainly in the intestines. In the tips of nose you see here, lips, external ear, that is the lobule of ear, and also you see in the digits, the digital pads, nail beds, you come across these type of arteriovenous anastomosis. So a direct communication between the arterioles and venules bypassing the capillaries. Venous anastomosis is between the veins or tributaries of veins. So superficially you come across a dorsal venous arch in the back of your hand or in the foot. You see this is actually the dorsal venous arch, which you can see here. So between the veins or between the tributaries of veins you come across this. These are actually venous anastomosis. So next we will actually discuss something about what is end arteries. So an end arteries is when the arteries does not take place in any anastomosis, directly it supplies the end organ through its branch. It is actually called as end arteries. The most classical example of end artery is the central artery of retina. If this artery is blocked, then naturally what happens is total blindness occurs. Central artery of retina, it does not anastomosis, so there is no chance of any collateral circulation here. The other branches are the cortical branches, which is going to supply the cerebral arteries, central branches. Splenic artery, branches of this is actually our end arteries. So naturally if it is blocked, then naturally spleen does not receive its blood supply, you have to go for splenectomy. Your renal arteries, which divides into 5 branches, are called as vascular segments. They again don't anastomosis. Then vasa recta of the gut, so straight arteries from the superior mesenteric arteries or inferior mesenteric arteries. They form vascular arcades, but ultimately they form straight vessels which is going to pierce the wall of the gut. When these arteries are blocked, then naturally that part of the gut tissue suffers blood loss or infarct. We call it as an infarct because when there is no blood supply. So most common areas when you see infarct is in the gut, spleen, renal, and in the cerebrum and in the retina. So end arteries means naturally no anastomosis and they are directly supplying the target tissues. So thank you very much for listening to this lecture. We will meet again in some other session.